Great, thanks for having me. I appreciate the opportunity to speak to medical students at any time. And I hope that this evening's lecture can be useful as you all think about your future career in neurosurgery. But even regardless of what field you go into, patients with back problems and neck problems are going to be everywhere. So at the very least, you'll have a newfound appreciation for people in pain and what we can do to help their pain get better. So without further ado, I'll get this going. Hopefully you can see my slides here. So I don't have any disclosures. We're going to talk about disc herniations today. I'm an assistant professor at Rutgers right now. I'm also the associate residency program director. So I'm definitely passionate about education. And again, thanks again for having me. Yeah, so basically my practice is I'm a board certified neurosurgeon. I'm about like 85% spine. So this is what I see day in and day out. I do deformity, but I also do a lot of revision surgery. Anybody that's going to be practicing, in an area that's densely populated, you will be doing plenty of revision spine surgery. And if you know how to do it well, you will always have a job, as one of my mentors, Dr. Hiri, used to say. I also do MIS, minimally invasive as well. And, I'm a primary faculty over at Rutgers. So what we're going to do this evening, and stay within time constraints, obviously, is talk about the types of neck and back pain one can have. What are the causes for this pain? And then specifically about disc herniation. So what are we going to do about it? What are some brief non-operative treatments? And then why would you do surgery? Like, when would you consider it? And then lastly, just a few cases to kind of hammer these points home and kind of bring it full circle. All right, so start with low back pain. Super common. If you go into neurosurgery, you will see it every day, basically. And 80% of people will have it at some point in their life, myself included. It just happens to us all. It's just a matter of how much can you take and what is the cause behind it. The most common cause of disability in patients under the age of 45 is back pain. And if you surveyed a bunch of workers, at least 1 out of 4 are going to say, yeah, I've had really bad back pain in the past 3 months. It's associated with female gender, age, working more than 60 hours a week. So, any future resident should keep that in mind. If, putting in these long hours, you might be at risk for it. So what are the types of flavors that you're going to have for back pain, and specifically disc herniations? Well, how are they going to present? They can present with axial pain, right? So like my neck hurts, my back hurts, it doesn't really go anywhere, it's just focal in those regions. And then they can have radiculopathy. So that means just pain in the distribution of a nerve, right? So I have pain shooting down my arm, I have pain shooting down my leg. It goes down the back of my leg, goes down the front of my leg, it goes down my hand, and I'm going to get into the details there. Then they can present with neurogenic claudication. You see that primarily in the older population. As seen here in this picture, they have the shopping cart sign. I lean forward and I feel a lot better. Then the way to consider back pain when you're evaluating these patients is it's going to come in one of these 3 flavors. It's going to be neck or back pain. It's going to be radiculopathy, so pain from a nerve in a distribution, or it's going to be claudication in the lumbar spine. And then the neck and the cervical spine, we have some a little more dangerous. We have cervical myelopathy, right? It's a pressure on their spinal cord in the cervical spine, and they therefore have trouble using all 4 extremities at times. So what type of syndromes are you going to see, and what can we attribute to a disc herniation? Well, first you can see these like red flag conditions, okay? And I'm going to just touch on a couple of those. You can have cervical lumbar radiculopathy, like we spoke about, claudication or myelopathy, or just some uncomplicated back or neck pain, right? So it's, again, the same 3 flavors. So axial pain, radiculopathy, or claudication/cervical myelopathy. These are the red flags. So no matter what kind of field of medicine you go into, you probably should keep these just in the back of your mind, right? So Cauda Equina syndrome, which I'm going to touch on only because it's not all that common, but it's something you absolutely cannot miss it. Infection's another red flag to not miss. Metastases, somebody with unexplained weight loss, a history of cancer. Severe progressive neurological deficit is another thing that you should not, you should work up right away. And then obviously a fracture, somebody who's at high risk. They've been using steroids for a long time. If they have osteoporosis, recent trauma, something like that. Okay, Cauda Equina syndrome, just real quick. It's going to present, it doesn't always present with all these findings, but they are germane to Cauda Equina. So you should know these. And they are limb weakness, it's typically bilateral. They will have bilateral sciatica, bilateral buttock pain. They will have urinary retention. Okay, so that is classic. So a patient comes in with Cauda Equina syndrome, they will not be able to urinate. you will be able to diagnose that with what's called a PVR, post-void residual. So you ask the patient to void, you then place a Foley catheter, and you see how much urine comes out. If it's over a liter, that's basically pathognomonic. You can be confident saying, yeah, this person likely has Cauda equina syndrome, barring any sort of frank urological issue that you completely missed. And then they'll have saddle anesthesia, and they can have loss of rectal tone. And a couple things about rectal tone, when you're out there on the wards, especially if you guys are third years or fourth years and you're examining these patients, your rectal exam is actually important. So there's two components to it for a neurosurgeon and neurologist and somebody that's worried about something in the spine. You want to see the voluntary anal contraction. You also want to make sure that they have deep anal pressure. So there's the sensation and the motor component. So always keep that in mind when you're evaluating them. To say that they don't have rectal tone is not as useful. And that can be very important if you're dealing with a patient with a spinal cord injury, okay? Those two findings can change a person's prognosis potentially. All right, so enough about that. The prevalence, again, of Cauda equina is very rare, like 1 in 3 per 100,000, okay? I've been in practice for a little bit, attending for like 5 years, and I've seen it once. And it wasn't even my patient, I was helping out a colleague. So it's rare. Again, it's I cannot overemphasize, it's rare, but super disabling. And it's worth mentioning, it's also a favorite of lawyers. So if you get one of these patients and you're in neurosurgery, you got to take them emergently. All right, so let's talk about lumbar radiculopathy. That's attributable disc herniation. Most commonly, L4-5, L5-S1. Okay, that's the bottom of the lumbar spine. And what happens is there's kind of two phases, right? So you have the disc herniation, and that inflammation and that irritation causes that acute, oh my gosh, my back's killing me, that pain, okay? Then they have that shooting pain shooting down their legs, and that can be more long-standing. And that is from the pressure on the nerve, okay? If there's structurally, the analogy I like to use for patients is like getting your thumb stuck in a door, right? Your thumb's in the door, it is killing you, but we take the door away, we do a surgery, it's still gonna hurt a little bit, it's still swollen. So, it's not something that gets better right away. And it can be exacerbated with sitting, bending, walking, coughing, these types of maneuvers. And the pain is usually in a dermatomal distribution, but the patients don't always read the book, right? So it's a little bit more general than that. So for example, I was just taught so L5 is a good one. It's going to be like the anterolateral leg down to the top of their foot. And I have a better way of showing this for you in a little bit, but the long and short of it is that they don't always read the book, but I will show you some tables to kind of help you systematize all of these, dermatomes and where these symptoms can arise from or how they'll present. So here's a disc herniation, okay? So the analogy I like to use is there's a couple. First of all, I tell my patients, think of them like brake pads, right? They wear out over time, okay? We don't have the same spine when we're 80 as we did when we were 8, it's the way it is. And what happens is these discs are filled with a jelly, nucleus pulposus, right? If you're taking your boards, you should remember that it is the embryonic remnant of the nodal cord, just a fun fact. And so the analogy I use is the jelly donut, right? So the middle is your nucleus pulposus, that's the jelly. And then the donut is the annulus fibrosus, okay? And what will happen in a disc herniation is some of that jelly from the donut has squirted out to the outside of it. And that's what's causing the symptoms, okay? So here's a nice picture showing that, okay? So if you could see down here, over here, basically, I'm gonna try to get one of these, markers here so you can see it. All right, so here's a nerve, okay? So it's always the same order, okay? Pedicle, root, disc, okay? Pedicle, root, disc. And so the nerve exits just below the pedicle of the like number vertebral body, okay? So if I'm at L4 here, this is my L4 nerve. This is then my L5 nerve. This is what we call the exiting root, and this is what we call the traversing root, okay? And where that disc is going to dictate what type of symptoms they have. So if a patient has a central disc, let's say this is L4, L5, okay? So if this is a disc at L4, L5, well, and it's a central disc or a paracentral disc, which is what we most commonly see, then it's going to affect L5. It's going to affect the lower number, right? If, however, it's what we call far lateral or a foraminal disc herniation, and it's out here, it's going to affect the exiting nerve. So it's going to affect L4, okay? And it's actually very critical to remember, okay? So it's pretty straightforward. So the nerve exits just below the number, the pedicle of the like number vertebral body. And then the way I used to remember it is, now I just see it too much to have to, I don't forget it, but At L4, 5, okay. If it's a central disc, it's going to be 5. It's going to be the lower number, right? And if it's a pyramidal disc, it's going to be the higher number. It's going to be L4. Okay, let's get to the next slide here. All right, so here's that table I was talking about. So lumbar radiculopathy, okay? Where's the pain going to go and what kind of symptoms are they going to have? So for L4, you're going to look at the medial leg. So they're going to usually have pain that's going to be in the groin region, but really the medial upper leg, okay? And it's going to go down to the knee. And sometimes it'll go past the knee, but rarely. So see what I say when patients don't always read the book, the dermatologist says it goes past the knee, but it usually doesn't. For L5, it does. So L5 is going to be the anterolateral leg, upper leg, down the anterior aspect of the foot, of the lower leg to the top of the foot. It's classic L5. And then S1 is that classic sciatica that you hear people talking about. My rear end really hurts. It goes down the back of my leg to the bottom of my foot. That's classic for an L5 S1 disc. And so they're going to have deficits referable to those disc herniations. So for S1, they're going to have numbness in the bottom of their foot. They're going to have maybe a little bit of weakness with plantar flexion. For L5, they're going to have potentially weakness in extensor hallucis longus, EHL, as well as some ankle dorsiflexion. And then for L4, they might have some weakness in dorsiflexion. So I would be remiss if I didn't mention cervical, okay? So these are cervical discs too. So we have, C3, 4, 4, 5, 5, 6, 6, 7, 7, 1, okay? And it's similar, but in terms of remembering as the lumbar, because what happens is now the nerve exits above the pedicle, okay? So it's still the lower number. So if we're at 3, 4 and you have a 3, 4 disc herniation, well, you're affecting the 4 nerve because the 3 root's already exited. It's exited above the disc, okay? So that's something to keep in mind. And so if we're at 3, 4, it's going to be up here in the shoulder region. 5 is classically the biceps, so it's a 4, 5 disc. Deltoid biceps are going to be affected. 6, they're always going to say I have pain right here, the 6 shooter. It's a way to remember it. So C5, 6 is going to be a C6 radiculopathy. C7 is going to be the middle finger and the posterolateral arm. They're going to have pain in their triceps. And then C7, T1 as a C8 radiculopathy will be the ulnar aspect of the hand. It'll be right here, okay? So just to keep in mind when you're seeing these patients and evaluating them. But the approach to disc herniation is the same, regardless if it's lumbar or cervical, right? We're going to try non-operative treatment, which I'll mention. And if they have, impending neurological decline or something, then yeah, maybe surgery, which, I'll address later in the talk. All right, so then the other thing that can be caused by disc herniation in the lumbar spine is neurogenic claudication, okay? So the disc herniations, they collapse. We have multiple levels of disc collapse in this picture. And as a result, the canal becomes tighter, the nerves are under pressure. And as a result, while the patient's walking, they get this low back, sometimes leg pain, more often leg pain. And it's this burning sensation. They'll say, my thighs really burn when I walk for a period of time. But when you examine them, they're completely intact, they're normal. And it's because of this neurogenic claudication. The nerves don't have enough room, and it's almost like an ischemic event at the microscopic level because of all the pressure on the nerves. They're not getting enough blood flow when the demand is increased. And this is something to keep in mind, especially for your medical clerkships, if you haven't already had them, this concept of vascular versus neurogenic claudication. And so if you have a patient that comes in with like lumbar stenosis, and that's why you're seeing them, and you find out that they're a smoker, that they have potentially vasculopathic history, you really want to work them up for vascular issues. And classically, what they'll talk about is you can, look at the table, but the classic thing is for vascular, they'll have rest pain. So they'll be sitting down and say, my pain, it still hurts, my legs hurt. And that could be an indicator of actually end stage peripheral vascular disease. So that's something to keep in mind. So the shopping cart sign, you can see why that works, right? So if you have a disc herniation and there's a lot of pressure on the nerve, and then you lean forward, you've increased the volume for the nerve. So you get like a temporary relief. And so like I mentioned earlier, for lumbar exam, a lot of them are going to be completely normal. They're just going to say that I feel weak and I can barely walk, but you examine them, all the motor groups are 5 out of 5, but then you see them walk down the hall and they got to stop after, 10 feet or so. The other thing to keep in mind, especially if you see a younger patient, let's say you see a 35-year-old man with lumbar stenosis and his spine looked like that, you should look at the neck because you could have an undiagnosed cervical myelopathy as well. So along that vein, cervical stenosis can be caused by disc herniations as well. A lot of patients can have radiographic evidence of cord compression without any symptoms. Doesn't necessarily mean you have to do surgery on them, but it's something to keep in mind, especially if they have lumbar pathology, but hyperreflexia, something on your exam that doesn't make sense, weakness in their hands, Hoffman's. And the other thing to keep in mind is once a patient develops symptoms of cervical myelopathy, they don't get back to normal on their own. This is one of the pathologies in spine surgery where we can say, no, without surgery, you will get worse. It's just a matter of to what degree. And this is a classic study, or a really landmark paper from Clark and Robinson in 1956. So what they did is they had 120 patients and they evaluated their natural history. And basically, most people will have what we call a periods of stability punctuated by a decline, and that's their new normal. Another 20% of people will just have a slow monotonic decline, and then a small group will have a rapid decline. Okay, so when people ask, what's the natural history? Now you know. So with patients with disc herniations in their neck causing cervical myelopathy, they might have neck pain, but it's more like a stiffness. They'll have extremity paresthesias. They can have difficulty with fine motor movements. They'll be unsteady on their feet, and then later on in the course, they can lose bowel and bladder function. On exam, they're going to be weak in their hands. They're going to have hyperreflexia. They'll be unable to tandem gait. So for those patients with cervical myelopathy, non-operative treatment really is not an option unless they're very medically sick, in which case, yes, you can observe. I mean, observation is always an option, but without surgery, they will get worse. It's just a matter of to what degree and how long it will take to worsen. So in the setting of cervical stenosis and cervical disc herniations causing cervical myelopathy, you're going to do surgery in the setting of progressive myelopathy and neurological deficits, okay? So that's kind of an overview of the types of pathologies you can see attributable to disc herniations. As far as, when you're seeing a patient with these problems, you're going to ask the same questions, right? Onset, timing, duration, quality, aggravating, alleviating, prior surgeries, prior interventions, have epidural steroid injections, which I'll mention, numbness, weakness, saddle anesthesia, things like that. This is an algorithm that we have at our hospital where basically if a patient comes in with back pain, this is a way to triage it. So in your head, you can kind of think about whether or not you're doing neurosurgery or orthopedic surgery or ER, it doesn't matter. You can have kind of the same framework, right? Patient has low back pain and they have neurological symptoms, then, well, yeah, you should get advanced imaging. You should get a CT or a CT scan. If it's just isolated neck or low back pain, you can work them up as an outpatient basis. So this is just something to keep in mind. So you've seen these patients. Now you think they might need surgery, but you're not sure. If the patient has like no neurological symptoms and it's just pain shooting down their leg, initial non-operative treatment is absolutely the way to go, which is going to be rest, ice, heat, medications, muscle relaxants, gabapentin, which is like a neuromodulator, maybe a short course of oral steroids if they're in a ton of pain. You might, for physical therapy, specifically, I always make sure my patients do McKenzie exercises. They're especially good for the low back. What this is basically the spine has a directional preference, and most spinal pain can be made better with certain changes in position. And so the point of a McKenzie exercise is to keep repeating these positions that make your symptoms better to a point where the pain is less. Then you can take on positions that were once more painful. And then eventually you're taking on those positions and now you don't have pain anymore because you're doing it repetitively. Obviously, an epidural steroid injection is another option. It's a common first-line treatment for a disc herniation. Okay, you can do them in the neck and you can do them in the low back. Basically, a needle is inserted into the epidural space, as you can see on this picture here. It's between the bone and the dura, the covering of the spine and the spinal nerve roots. And it simply just diminishes inflammation around the nerve root. You kind of quiet things down a little bit. Some people do great with them. And patients that are older, that might not be that ideal surgical candidate. There are patients that, they just get their shot every few months and that's it. And that's their status. And obviously it could potentially obviate the need for surgery. Another type of injection is a facet injection. If somebody has a ton of pain, maybe radiates down the leg, but their disc hurt, the disc doesn't look that bad, you can inject the actual facet, the joint in the back. And then lastly, a selective nerve root block is a very good, not just diagnostic study to request, but also therapeutic. So what they'll do is they'll actually inject along the nerve. And if the patient does great, then you say, all right, this is where your pain's coming from. If they have no response, then you might have to think of something else. All right, so let's kind of work our way through cases and talk about, and in doing so, describe the different types of treatments that are available, surgery and not surgery. So if you have a 48-year-old person and they just have low back pain that gets worse by the end of the day, I'm sorry about that, and the exam's unremarkable and they have that MRI, you're going to recommend physical therapy. At least I hope you would. Okay, that's not something that's obviously surgical. So why are we going to do surgery for disc herniation? Well, progressive neurological deficit, failure to respond to non-operative therapy. So they have a disc herniation, they've done physical therapy, they've done injections, they're not any better. And then obviously they have progressive symptoms. So usually that all happens together, right? So you have the patient, they have really bad, let's say back pain goes down the leg. They've done physical therapy, they've done injections. Despite these efforts, they're still getting worse. Surgery is reasonable. So here's a woman. Let me just make sure I can see top there. Yeah. So this we have is a 60-year-old female. She's got 2 weeks of left leg pain. She's got foot drop. I remember this woman. She was shoveling snow during a snowstorm. And when she was done shoveling, she got this really terrible pain in her low back radiating down her left leg to the top of her foot. And she had a foot drop. And this was going on for 2 weeks. And on exam, this is her MRI. Okay. I want to make sure you can see. And basically, this is an axial T2 weighted MRI. Okay, on T2, the fluid is white. These are the nerves. I always analogize them to, it's like spaghettis in water. Okay, and this is where the disc is, and you can see that you can see the nerves, the little spaghettis, really well here, not so well there. Okay, and then this is a more impressive view. This is the sagittal view. So this is the side view, and you can see that nerves are okay everywhere, but here there's this big disc herniation. So, I mean, we have this woman that's presenting with 2 weeks of symptoms. So, okay, from a pain perspective, we probably should try non-operative treatment, but she has a foot drop. I mean, that can be a very debilitating thing. So this woman, I admitted her to the hospital as soon as I saw her, and I did a microdiscectomy. So I'm going to try to show you. Well, I mean, I have a picture of it. I don't have a video of it, unfortunately. This is just the CT scan. So part of the workup, I always get a CAT scan to make sure the bones are okay and that the disc isn't a big piece of bone and rock. This is a flexion extension X-ray showing no instability. So this is a microdiscectomy. So these are the pictures showing what we do. And I'll kind of go through them one step at a time. So basically an incision is made down the middle. Sometimes you can do them through a tube, but regardless, you see the same thing. So this is the lamina, okay? Lamina here too. A window is created in the lamina. So we remove some of it. People always wonder, like, how much bone can you remove before you cause a problem? You remove a decent amount, but basically you cannot remove more than a third of the facet. So this is the facet joint right here. Okay. This is what's called the inferior articulating process. This is the superior articulating process. We can take about a third of the facet. So we can get in the space here, right where the disc lives. And if you can see it right here. Okay. That's where we're going, right where the disc is. Okay. So she did a microdiscectomy. She went home, I think, after a day and a half in the hospital. And I saw her in the office, and I haven't seen her since because she's normal now. So that's the beauty of microdiscectomy. It's a very effective operation. But again, the patients that are going to benefit from them are either progressive neurological symptoms, obviously called Equina, you need to do right away, or they've tried non-operative treatment and they're not getting any better. And we typically recommend at least 6 weeks of non-operative therapy. Okay, so let's see another one. So this is a 92-year-old female. She has low back, leg pain. Worsening with difficulty with ambulation, climbing stairs, walking. The numbness in the legs gets worse with walking. She complains of this burning sensation in her legs. Okay, you examine her, she's intact. She's done physical therapy. She's done steroid injections. This patient here. So this is another view. Remember the spaghettis in water from the last lady, because she basically had a focal disc herniation. This is a little different, right? This patient has multiple levels of disease, and you can see here that the spinal nerves are being compressed. Okay. And so this is a patient that I would recommend for a laminectomy. Okay. She's 92. I'm not interested in fusing a 92-year-old. Okay. Let's just make room for her nerves, get her better. So that's exactly what we did. So we did a laminectomy. So in a laminectomy, it's similar to the surgery we just talked about, microdiscectomy. So in that setting, in a microdiscectomy, right, we're removing just a window of bone. Okay. We remove this little window here to get to the disc. In a laminectomy, you remove the whole back. Okay, it's called the lamina, right? So laminectomy, and then we just go out a little bit more lateral than this, just to make sure that all the nerves have plenty of room. And she had a laminectomy. She was discharged to rehab. She did pretty well, actually. So, again, a laminectomy is a completely reasonable surgery, especially if you have somebody with multiple levels of disease, particularly common in older people. And it's a very, it's tried and true operation. It's one of the oldest operations that a neurosurgeon does. All right, so we're not just talking about the back, we can also talk about the neck. So this is a 32-year-old guy with a disc herniation. Okay, he's got severe neck, right arm pain for 2 years, no improvement with physical therapy. He's had an injection and he did great with it. He got a lot better, but it was unfortunately transient relief. Okay, so the C5, C6 level. Hopefully you can see here, this is C5, C6. Here's the CAT scan here. And just take my word for it, there's a disc pushing on that C6 nerve root. Okay, so he had pain going down to his 6 shooter there. So his index and pinky finger, or index and ring finger, thumb. So for him, this is a disc in the neck. So the approach is a little different. There is an analogous procedure in the neck as a microdiscectomy. It's called the laminoforaminotomy. But given the fact that he had so much neck pain, I didn't think that was the right move for him. Instead, I wanted to do something about the disc up front. And one can think, oh, okay, an anterior cervical discectomy infusion. That's a index operation. The problem is he's 32, right? So if a patient, once you have a fusion, it begets further fusion potentially. There's a landmark paper out of Jefferson that basically every time you do an ACDF, so for each for the adjacent segment to break down, okay, we call it adjacent segment disease. So if I use C5, C6, the risk is 2.9% per year up to 10 years, and it's cumulative risk. So basically, if he lives to be like 10 years, there's a 1 in 3 shot that he's going to need a revision operation. So instead, what a great option for patients of this age group, younger patients, is this. It's called a cervical disc replacement. So basically, what we do is we go and we do the same approach as we would do for an ACDF. Okay, we remove the disc in its entirety. We make sure that the nerve has plenty of room. Okay, so all this gets removed, but we're not doing much bone work. Okay, we're not doing fusion. And what we do is we implant a device here that will function as his normal disc. So now this patient will still be able to extend, still be able to flex and rotate, but that disc is gone, the bad disc. Okay, so I think this is a great option for younger patients. And so, patient will come into my office explicitly asking for this procedure. So if you go into neurosurgery and doing spine, this is something that should be in your armamentarium. So yeah, just about disc replacements or arthroplasties or TDRs can definitely be considered in 1 or 2 level disease. It's not so well. The only thing is patients are not indicated to have it if they already have really bad facet degeneration or really bad arthritis. The other way of thinking about it is, our spine wants to fuse. As we get older, our discs degenerate and our bones want to fuse together. So if you have like a 65-year-old, yeah, disc replacement probably not a good idea because you're going against natural history, right? You're removing this disc that wants to fuse and you're replacing it with something that won't fuse, as opposed to somebody that's 32 where they have a long life ahead of them. You want to just replace the discs and you want to preserve the motion. So that's a disc replacement in the neck. They do them in the lumbar spine, but I don't have a lot of experience with them, so I've omitted them from this talk. So here's another one. So this is a patient with not only a disc herniation, but bad alignment in her spine, okay, which I'll talk about. So this is a 68-year-old female. She has low back pain, right L5 radiculopathy. So it goes down the anterolateral leg, down to the top of her foot. She has some weakness associated with it. Her pain is mostly in the leg, but definitely back pain as well. And what you can see here is that the bones don't line up, okay? That's called a spondylolisthesis, spondy-spine listhesis motion, like a misalignment. And as you can see here, she's got a disc herniation, okay? And actually, fun fact is, in a spondylolisthesis, in a true spondylolisthesis, not necessarily a disc herniation, it's what we call pseudo herniation. Because what happens is the bones, one bone slides on top of the other bone, and you're left with this uncovered disc here that then is putting pressure on the nerve. But the pathogenesis isn't the disc, it's the bad alignment. So it looks like a herniation, but it's actually a pseudo herniation, in case you get asked this, on your sub-I's. So regardless, she has bad alignment, it moves. So we basically approach this with a fusion. Okay, this is called a, let me just erase that mark. All right, so basically what we did is a single level fusion on her. We have screws that we place in the pedicle, okay, right here and here. screws are inserted, and then we remove the disc entirely and place an implant in the disc space that will turn into bone over time. Okay, that's fusion. It's a type of fusion. It's a transforaminal lumbar interbody fusion, TLIF. Okay. Just a couple more, and then we'll do some questions. Here's another patient, similar surgery. So 67-year-old female. She had low back pain, same thing, spondylolisthesis. Okay, right leg pain for 12 weeks. She had epidural steroid injections, no improvement. And so again, you can see here the bad alignment. So she has this bad alignment. We go ahead, and this was actually done minimally invasively. So we make 2 small incisions in the low back. We go down with tubes. On the more symptomatic side, we bring down a tube and remove all the bone, push it on the nerve, and then remove the entire disc and replace it with an implant that will turn to bone over time, called a cage. And this lady did very well, and with a minimally invasive approach, they're able to leave the hospital much more quickly. And that's what it looks like, the minimally invasive approach. Okay, what we do is 2 small incisions in the low back, or at least the way I do it. 2 small incisions in the low back. We go down with a tube. One side we place screws, and on the other side we go down with the tube and remove the bone, and then place a cage that will turn into bone over time. So that's kind of like all the big cases. So I mean, evaluation of these low and back pain patients with disc herniations, it's a really individualized approach. Okay, it should be comprehensive and individualized. So, and really to make it comprehensive, it should be a multidisciplinary team. So you're going to have pain management doctors, physiatrists, physical therapists, and everybody kind of work together in concert to determine the best course of treatment for these patients. And I cannot overemphasize, non-operative or conservative treatment is the first line for these patients. Okay, unless they have some sort of severe neurological decline or symptoms, you're going to want to do physical therapy and injections first. Once they've demonstrated surgical indications, though, that's fine. That's why we're here. It should be a patient-centric algorithm. So you need to find the right surgery for that patient, not the other way around. Not like, I'm really good at doing this surgery, so everyone's going to get it. No, this person has a single level problem. You're going to give them a single level surgery. This person has a big deformity. Okay, they're going to get a deformity surgery. But at the end of the day, the surgery is tailored to the patient, right? Not the other way around. Always remember that. All right, ready to take questions. I see them popping in the queue there.
Hey everyone, Ryan Rad here from Neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.